Welcome, everyone, to another episode of hashtag CRA Arthritis. I'm Kelly Lenvoy, and I'm very pleased to welcome back to our show a good friend of ACE's, and that is Dr. Walter Maksymowych. He's a professor in the Department of Medicine and Dentistry at the University of Alberta. He's a co-founder and principal investigator at the Spondyloarthritis Research Consortium of Canada, and that's been established to develop biomarkers and imaging technologies for this form of spinal arthritis. Dr. Maksymowych, welcome.
Well, thank you very much, Kelly, for inviting me to speak to you and to the good folks at listening into the Arthritis Broadcast Network. It's a great pleasure to talk to you, Kelly, and I'm very excited about the developments we're going to be discussing at the Canadian meeting in Halifax.
That's right. You're in a workshop on translational science and
Yes.
focusing. Your abstract focuses on a novel diagnostic biomarker for axial spondyloarthritis. And I thought we could get started for the benefit of our audience um, to maybe first define what is a biomarker and why are they so important in diagnosing diseases like axial spondyloarthritis.
Yeah, so a biomarker is basically something that we measure, and it can be something in the blood, so a blood test, um, to measure kidney function or liver function. So we're actually using biomarkers all the time in routine practice, in routine medical practice. A biomarker actually can also be an imaging test, an MRI, a specific indicator. A biomarker is an indicator of something that is happening in the body. And you may use a biomarker to measure normal function of a human organ, like the heart or the kidney or the lungs. But we also, of course, use lab tests to measure abnormalities that may be occurring. And in this case, we're interested in evaluating the inflammation that occurs in people with arthritis. We're particularly interested in people who have arthritis in the spine, and that is really a tough nut to crack. It's a tough nut to crack because so many people have back trouble. And trying to figure out, is it a mechanical problem, overdoing some work, shoveling the snow, etc.? Or is it a specific inflammatory type of arthritis? And that is just so important because if it's an inflammatory type of arthritis, we can treat it, and we can treat it highly effectively with relatively safe therapeutics long term. We don't have a cure, but we can control the inflammation. And so it really is super important that we develop very sensitive tests that can pick up that there's a problem that could be inflammatory spinal arthritis. So that's what we're going to be talking about.
Yeah, and certainly our audience, if they're familiar with some of the work that we've done in this field, we have a joint health education program focused on spondyloarthritis. They know that there's a real issue and challenge about diagnosing and early diagnosis for people with the disease as well. So your research focuses on a new biomarker called 1433 ETA. What makes it different from what we currently now use to diagnose axial spondyloarthritis?
Well, currently, what we have is a genetic test called B27. And B27 is actually a healthy gene. If you have B27, it doesn't mean you're always going to get spondylitis. So, maybe only around 5% of people who carry the B27 gene actually get spondylitis. And so it's not enough that we just have this genetic test. Another test that we use is something called C-reactive protein, CRP for short. So people with arthritis will often have had that test done. But the problem with that test is it's not that sensitive. In other words, it only picks up around 40% of people who have this type of arthritis. It's also not very specific, which means that it's also positive in people with other types of arthritis, and it's even positive in people who carry excess body weight. So it's totally non-specific. So we have a big gap in the field, particularly if we want to have an early diagnosis, because, these tests don't really help us a lot. And if we wait for an x-ray, well, we're going to be waiting 5 to 10 years. And we've got to do something to help patients. We can't wait 5 to 10 years, especially when we know that there's something effective that could make a difference to the lives of patients.
So how does the new biomarker help identify the disease earlier?
Okay, so it's actually kind of a strange story, and it actually begins with studies in patients who have burns.
Huh.
Patients who have burn injuries, their fibrous tissue goes into overdrive. They're repairing the burn, and there is an attempt at repair. It's an extensive wound, and there are these fibroblasts or cells that make lots and lots of scar tissue, and that's why people with burns often have lots of scar tissue. And it appears that in burns patients that there is a very important protein called 14-33 eta that drives the activation of these cells that
Hmm.
produce all of this scar tissue.
Hmm.
And about 15 years ago, um, I was speaking to an investigator who was very interested in understanding why some patients with burns develop these really quite nasty scars with too much scar tissue. And we were having a very interesting conversation over lunch. And he said, yes, I found this factor called 14-33. And what it does is it activates these fibroblasts. And that sort of set some bells ringing in my head
Hmm.
because I know that fibroblasts are a big deal in arthritis.
Hmm.
So patients with arthritis have very active fibroblasts. In other words, when you have inflammation, and it can be in the hands, the spine, the hips, the knees, anywhere, there are many different types of cells that are activated. There are cells that are causing inflammation, but also cells that are trying to repair tissue. And the cells that are activated include these fibroblasts that produce this 14-33 eta. And so this 14-33 protein substance, which is such a strong, potent activator of these fibroblasts, we found a lot of it in patients with rheumatoid arthritis. And so it's actually now commercialized as a test
Hmm.
in North America and the UK. And there's something like about 200,000 tests are done.
Hmm.
And this test was developed in Canada as the latest new test for diagnosing rheumatoid arthritis. And so when we were testing how specific is it for rheumatoid arthritis, we tested a lot of different diseases. But we didn't just test the protein, we tested the antibody to the protein because we also wanted to know if people were making antibodies to this protein, to this 14-33 eta. And indeed, in rheumatoid arthritis, they do make these antibodies. So it's not just the protein, but it's also antibodies to the protein. So we then started looking at other types of arthritis. And it was when we looked at patients with spondylitis that we saw that they were making antibodies to this 1433 eta. And this antibody occurs in around 60 to 70% of patients with spondylitis. So it's more sensitive than what we have right now, which is the CRP protein. And in addition, we also see that these antibodies don't occur in healthy people. They occur in people with spondylitis.
Mm,
So it's specific for spondylitis. So it's a completely new test. It's related to this activation of fibroblasts. So we know that there are attempts at tissue repair. When the inflammation has been triggered, the body reacts. There's a repair response. And part of that repair response is the production of this 1433 eta, and the human body produces antibody. It's that flag that tells us that there's a repair process taking place. How do I know? Because I can measure the antibodies that are occurring. So when I see that these antibodies are present, I know that this patient is mounting a repair response.
mm,
So it's sort of, an interesting way to look at arthritis, because in the past we've always only thought about inflammation, 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 inflammation. And we've never really thought about the clues that we might get from understanding how the body repairs itself
mm,
from the inflammation.
mm.
And now we're learning that, yes, there's a very active tissue repair response, and we can understand this through the measurement of these antibodies. And so now the other thing that we are very interested in exploring is whether these antibodies might predict the severity of the disease.
Mm.
And that's very important to rheumatologists, because if we can do that, then we can institute more aggressive, more intensive treatment sooner rather than later.
So that's, I mean, first of all, um, our audience knows that we talk about the patient journey all the time. What's great about this program that we do with the CRA annual meeting is we follow the scientific journey. And what you just described in terms of that meeting 15 years ago and where it's evolved from there, the process of discovery is so fascinating. I'm thankful that you're able to take the time and let us sort of join you on that journey that you've been on. It's really really incredible. What you've touched on that at the very end there is a question that I would like to close the interview with, and that is sort of linking back to the workshop, your workshop title, and that's translational science. And looking ahead, how do discoveries like this, of the new biomarker, fit into the broader goal of what our audience has heard us talk about many times, and that is personalized or precision medicine for people living with a rheumatic disease?
Yes. So the way it ties in is, first of all, we can make an earlier diagnosis now. And so that's certainly important, because we can distinguish spondylitis from mechanical causes of back pain, slip discs and stuff like that.
Sure.
So the second way that it can make a direct impact on personalized medicine is really by helping us to identify which patients may have the more severe categories of disease. Understanding disease severity, understanding which patients are more likely to have the more severe variants of disease is super important, because we really want to know which patients we should be treating earlier in the disease course.
Yes.
And it may also be that people who have this biomarker require a different type of treatment,
Mm,
that the standard approaches may not apply.
mm.
So, as we can characterize patients in more detail, and we hope to find additional biomarkers that sort of give us a fingerprint of what's happening in that patient, that will help us to point to a more personalized, a more tailored treatment plan. That's what we're looking for with each patient that we see.
Well, it's very exciting. It's always a pleasure, Walter, to speak with you. You're doing, pioneer work and one of the leaders in Canada. So we're always very thankful that you're able to join us, and you are a good friend of ACES. Thanks for joining us again today.
It's a pleasure anytime, and I'm always delighted to speak to patients. Thank you so much.
Of course. And thank you to our audience. And we look forward to seeing you on another episode of hashtag CRA Arthritis. Bye for now.
Bye bye.